Okay, today we are going to go over my AT630 presentation, Peripheral and Spinal Mechanisms of Pain Control. So, my next slide here, introduction. I might have taken a different approach to this than some people. There's only been 2 people that have gone so far, so I'm not really sure the direction many people will go. I took a very basic science approach to this project. Why? Mostly because that's where I struggle in. I've identified that in my plan of advanced practice, that I know I'm not where I want to be and where I necessarily need to be in my basic sciences. And it's tough admitting that, but it is what it is, right? Move on. You identified a weakness, and how can we improve that? I think that's why Dr. Nociceptive and Dr. Siegmiller picked this topic for me, because they realized that I am lacking in this. So, peripheral and spinal control. Peripheral control can mean a multitude of different things that we'll get into here throughout the presentation, and spinal control, same thing, we'll get into this. So how can I tie this into my interests? Well, one, I want to do positional release therapy. I see a great need in my patient population that I treat, and as in my last presentation a couple weeks ago, I talked a little bit about positional release and how I think it would help the chronic pain, the chronic dancers that I see. So definitions of pain, you can see pain and dysfunction are reciprocally linked. Lund et al. In 1991 had this definition: dysfunction causing pain which then causes more pain or more dysfunction. So dysfunction causing pain, which then causes more dysfunction. So if you have a dysfunctional movement, it can cause pain, which causes more dysfunction. We see this a lot of times in runners, IT band issues. I myself have a chronically painful, tight left IT band. I'm sure I walk differently. My gait is altered because my IT band is tight. Is that dysfunction? Probably. It can be for me. If I took the SFMA or FMS, I wouldn't do that well on it. So pain is personal, subjective experience influenced by cultural learning, the meaning of the situation, attention, and other psychological variables. This is by Katz et al. In 1999. A little bit newer definition of pain. If you look in literature, if you look in textbooks, there's not one universal definition on pain. I teach the modalities class this semester, and this, first couple chapters we're going over pain. We couldn't find a good definition of how we wanted to define pain. So how do you define pain in your clinical setting, your clinical practice? For your patients might be a little bit differently than how I, as an athletic trainer, a clinician, an ACI, whatever you want to call me, define pain. And that, I think, is okay to a point, but we need a universal definition. Don't know if we'll ever get there, though, because pain is different in every single person. How many descriptors of pain do we have? Sharp, dull, achy, burning, there's the list can go on and on. 2 different types of pain fibers I want to talk about. You have A delta fibers and C fibers. So the A delta fibers are the big guys. They're large fibers. They're slightly myelinated, so they're very fast. We typically see this with acute pain. As DeLeo 2006 says, acute pain, immediate withdrawal. So we touch a hot stove. That hurts. Let's remove the hand from the stove. We break our femur. We fracture our femur. Ow, that's a lot of pain. We know that immediately. So that's what we see a lot of in athletic training. Sports, football, the contact injuries, acute injuries in football, ice hockey, lacrosse. That's what we typically see. C fiber, different, small. S, you understand the L and the S here in a couple slides when we go over gait control. So small fibers, they're unmyelinated and they're slow. Unmyelinated, the nerve impulses do not transmit that well. See this a lot more with chronic pain. This was what interests me because I see chronic pain all the time. It is very rare for me to see an acute injury in my clinical practice with my patients. Most of what I see are dancers that have been dancing for a couple weeks on end with very little rest and develop some kind of dysfunction that could cause pain, but they don't say anything because they want to keep dancing through it and keep performing just like a normal athlete would. Develops into a chronic pain syndrome, chronic pain cycle. It gets stuck in the inflammatory cycle, and it can't go past that. So I'm interested in some of the things that we could do to help the C fiber with the chronic pain. Don't know if we'll get there or not. Pain-Spasm-Pain Cycle. So muscle spasms cause pain. Pain reflexively produces a muscle spasm. It's a self-perpetuating cycle. It's going to be established. It's a never-ending cycle. Two authors talk about this old article, right? 1942 is the original article. Travell et al. And Rowland in 1986 discussed this, the pain-spasm-pain cycle. Implications in an orthopedic and athletic model. So in the traditional athletic model, college, university setting, you tear an ACL, what happens? Your quadriceps, hamstrings go into spasm. Spasm can cause that pain. Vice versa, you're in a car accident, you have a whiplash injury in your neck. Your muscle goes into spasm and causes the pain. And then it causes more spasm. So what can we do as an athletic trainer in the traditional model and outside the traditional model, right? Athletic trainers are working in a multitude of settings right now, not just college athletics, high school athletics. We're working in, obviously, dance companies, industrial rehabs. You guys know all that. So how can we treat each individual as a person and as a patient to stop this pain-spasm-pain cycle? Two more articles here. Cobb et al. in 1975, getting a little older now. Does pain cause spasm or spasm cause pain, right? So Cobb et al. 75, injected pain-producing substances into the body of a set number of patients. He wanted to see if the injection would cause spasm to occur in these individuals, and it did. He found that it did produce spasm. It also caused pain. Obviously, if it's a pain-producing substance, it produced the pain first. Secondary to that pain was the spasm. So why did that happen? Lewis et al., 1920, even older article. Seminal article of the time about substance P. He discovered the substance P for pain control. Substance P, you might have heard about it, a little bit of the gate control theory going through college. Substance P is associated with inflammation and pain. So we see that after any acute injury. You sprain your ankle, you have any type of injury really, you have pain and inflammation. Why do patients come see us as athletic trainers? Well, they're probably in pain. If they come into your clinic, they're not coming in there because they're feeling good. It's like being a human resources director. People don't come to you because they love their job. People are coming to you because they have an issue. So I like an athletic training to very similar to a human resources director. You might see good people, you might see bad people, but at the same time, you got to help them out with their problem. In our case, it's pain. And the HR director, who knows what it could be. So substance P associated with inflammation and pain. Some definitions here as well as when we get started here. So nociceptors, however you feel the correct pronunciation is, they're afferent neural activity transmitting sensory information about noxious stimuli. From Treddy, 2006. So noxious stimulus might be an injury. It could be a baseball player getting hit with a pitch while they're up to bat. Be anything that causes pain. In my modalities lab, I want to cause a noxious stimuli to one of the students. So what did we do? We had the one student that was the only guy in the class who can't hit a girl. So the guy laid on his stomach, and we punched his calf repeatedly for 5 straight minutes, taking turns until he got a little ecchymosis, had some bruising, and had a little bit of pain. Then we hooked him up to a couple different types of electric stim to see if his pain would decrease. Took temperature measurements. We did a couple different data measurements, outcome measures, and I think it was beneficial to the students, and the student didn't care about getting punched, which was good, and should have made him sign a waiver, right? Don't sue me. Oops. 2 other terms that we hear, but we might not have heard of for a long time, especially if you're not, if you're not teaching this, you might not hear this every day. Afferent, efferent. Afferent sensory nerve enters the spinal cord via the dorsal horn. Efferent motor nerve exits the spinal cord via the ventral horn. So afferent is a sensory nerve, and efferent is a motor nerve. This will be more important as we get along here as well. So these terms, again, like I said, you've heard them before. We've all sat through a modalities class. We've all sat in different lectures about anatomy, physiology, exercise physiology. It's just you don't use this stuff every day, you kind of forget it. And I honestly did until I started prepping for modalities class. I'm like, wow, man, I haven't heard these terms in so long. So I talked about nociceptive pain. It's pain caused by peripheral nerve fibers, thermal, mechanical, chemical, thermal, hot, cold, mechanical, getting punched, chemical, you get, I don't know, something in your eye that causes an irritant. So you're making dinner and you get some pepper in your eye. That's a chemical-induced nerve fiber issue. So a lot of the articles I found on this topic discussed visceral and superficial pain. We talked a little bit about this with Jen, I believe, who did the PRRT, about visceral pain. So this could include orthopedic injury, sprains, fractures, usually a deep pain that can also affect the internal organs. So the one article talked about all the pain should be going to the gallbladder, but it's not. It's going to the ankle. It's going to the head. It's causing headaches instead of going to the gallbladder. So a lot of the PRRT stuff is set up based on this. Now there's not a lot of research on it. There's not a lot of, scientific background that I know of. I'm not researching that and basing that on in theory. I think that the body does get up, if you will, and I think that's why visceral pain. So superficial pain, it's minor skin wounds. Superficial pain, I think we all know what that is. So, big theory here. Gate control theory of pain. How many of you guys have thought about this before, or since you've had this maybe in a class? You don't think about it every day. We don't use it. We kind of forget about it. We know it's there, but we kind of, Melzack et al., 1965. Melzack guy was like the man for pain. He wrote this article, it's a seminal article on pain, 1965 from McGill College in, Toronto, Canada, I believe McGill is. So we get a lot of pain things from McGill University, the McGill Pain Questionnaire. I think the Ottawa ankle rules were even developed in McGill. So Melzack and the work he's done has set up him and his university for decades upon decades of research into pain. So it's the main theory on pain. We've had this before, but the substantia gelatinosa, the SG, modulates afferent patterns before they influence T cells. Afferent patterns activate select brain processes that modulate a gate-type system, and the T cells activate neuromechanisms for which comprise an action system responsible for the perception of pain. So, large fibers and small fibers. Remember I said that would be important. The L and the S a couple slides ago. Second or third slide I had on here, right? So the L and the S. L stood for A delta fibers. These are the large myelinated fast fibers. Acute pain. The small fibers were the C fibers. These were small, unmyelinated, slow, chronic pain fibers. So now about peripheral pain. To me, peripheral pain includes anything orthopedic-wise. We have an orthopedic injury. We have, as I call it, a slap on the wrist. Causes pain. After injury, what's the first thing we look for is pain. Causes pain. Pain increases the neurotransmitter enkephalon. Enkephalon is a specialized neurotransmitter that can block A delta and C fiber signals to T cells. Enkephalon is released by sensory stimulation. Carr et al. 2011 talks about this in his article. Baseball. I grew up playing baseball. We always had a joke. If you got hit by a pitch, we always said, don't rub it, don't rub it. You're a baby if you rub it. Walk to first base, you're fine, don't rub it. Well, that's in direct opposition of the gate control theory of pain and peripheral pain. So if I slap myself on the forearm and I don't do anything, yeah, it kind of stings, but if I don't do anything, enkephalon is not released, A delta, not really C fibers, but A delta fibers are being released to my spinal cord, telling me, ow, that hurts. If I do it again, and I rub the area, it feels better. Why? Peripheral pain control. Enkephalon is released by sensory stimulation. As soon as I start rubbing that area, enkephalon is released and can block the A delta fibers. After an injury, what do most athletes do? They grab the injured area. If you have somebody who tears an ACL, what do? They grab the knee. Roll an ankle, they sprain their ankle. What do? Grab their ankle. Very, very rarely will you see somebody tear an ACL, sprain an ankle, and not want to touch it at all. So we can do things as an athletic trainer to help manage that pain. And this is where this topic got very tough for me to distinguish how I wanted to go about this presentation, because I know another classmate has the electrical modalities. So I talk a little bit right here about TENS units. So TENS units, the whole theory behind TENS units are blocking the sensory fiber pain from the A delta to a point C fibers and releasing the enkephalon. We can do this with therapeutic massage as well. It feels good, it's a sensory stimulation, and helps with peripheral pain control. So these are two things that we can do in the athletic training clinic to help decrease somebody's pain. Carr et al. Again examined 45 patients who had lumbar discectomies, put them up in two groups. A TENS unit group with a drug that they were getting, an analgesic, or the other group was just a drug. They didn't have a TENS unit at all. The surgeons did the lumbar discectomies. The one group got only the drug. The next group got the drug and the TENS unit. The TENS unit, as you can see here, was administered twice for 30 to 40 minutes each, with 3 to 4 hours rest interval between treatments. This was the first day and the second day after surgery. To me, this study was more action research because the methods were a little bit looser, which was refreshing for me to see, but at the same time kind of caught me off guard. So when the TENS unit was administered 30 to 40 minutes with a 3 hour to 4 hour rest interval, they found analgesic consumption in the TENS unit group was lower, and the visual analog pain scale was lower. So these individuals had a catheter IV with the drug, obviously in the little IV bag. They could press the button, it would release the drug, it would give them pain relief. They found that the patients who had on TENS units decreased the amount of clicks they would hit the button, decreased the amount of drug they would take, and they felt better 2-3 days after and long term. So TENS with analgesic, so TENS unit with medicine seems to decrease pain. At least it did in this select group, this small group, lumbar discectomy patients. I think it would be very interesting, and I think I put this down in my 10 questions at the end here, to see if there'd be any effect without the analgesic, without the pharmacological agent. If I put a TENS unit on as soon as somebody gets out of an ACL surgery, will that decrease their pain and have a better outcome later on? I don't know. I think that would be a kind of a cool project that, you know, with dance I probably couldn't do because I haven't seen an ACL yet, but in a larger university setting, you could probably do this pretty easily. You know, take your ACL patients that year that you have and put a TENS unit on them, obviously get their consent and all this, and hook up a TENS unit to see if their pain decreases over time and track their outcomes. Are they getting back better or quicker? Do they have less pain? Are they accelerating through the rehab more? Are those good things or bad things? I don't know. It's just a question that came to my mind. So, spinal mechanisms of pain control. So what spinal mechanisms can decrease pain? So we can use a mechanical device to alter A delta and C fiber pain. Desmoulin et al. 2007. So these guys designed their own, looked like a torture device. It's called the KKT machine. I liken it to a joint mobilization type machine. I believe these guys were chiropractors or osteopathic physicians. And they would use this mechanical device to perform joint mobilizations to a point, manipulation, on individuals' necks, so people with neck pain, patients with neck pain. And they found that the mechanical device made them feel better. So a lot of that is based on the osteopathic and chiropractic model of healthcare. They think that a joint is subluxed, pinching a nerve, causing pressure on a nerve, causing dysfunction, right? So by adjusting that, by putting it back into proper alignment, we get rid of the dysfunction and it decreases the pain. And I think that this could be true now that I'm getting more into positional release therapy, and I've worked for a chiropractor who was also a physical therapist, and I do see that. A lot of pharmacological agents in the research I found that alter A delta and C fibers by drugs. Lond et al., Meslak et al. That had no data attached to it. Central nervous system mechanisms of control. So a lot of these pharmacological agents increase sensitivity to the dorsal horn of the spinal cord and block the neurotransmission site. So morphine, classic example, morphine. It takes a receptor, neurotransmitter receptor. So the neurotransmitter, say a pain, whatever pain may be, instead of the pain attaching to that receptor site on the neurotransmitter, the drug is attaching to that. The drug is attaching to that morphine, going into the receptor site like a lock and key, right? When that happens, your pain decreases. Now, I don't necessarily like the pharmacological agents because there's a lot of prescription pain abuse, misuse, dependence, all that. When I was in southern West Virginia, my personal experiences, I saw a ton of prescription pain abuse. West Virginia was huge on prescription pains, morphine, anything they could get their hands on, they would take it. But the whole point of this is it does increase sensitivity in the dorsal horn of the spinal cord, therefore decreasing the pain in the gait control theory of pain. Some of the other articles I did find were working with trying to implant a device in the brain and altering brain signals. To me, that seemed very far-fetched for an athletic trainer to do. We're not surgeons, we're not trained in that. And I kind of shied away from those articles for this topic because I didn't feel that really would show how to control the pain, either peripheral or spinal mechanisms. So this is a picture, this is out of the modalities textbook, dorsal ventral horn with the gray matter, afferent fibers coming in, coming out. Just wanted to show you a little picture of what that looked like. So some more spinal mechanisms of pain control. We're not there yet by any means, not fully understood yet. In 300 plus years of medical type research. Only one pain theory existed. DeLeo, 2006, in his article, which I think is one of the best articles, it's called The Basic Science of Pain. I posted that on task stream for everybody. I like the article because it's basic science of pain, and that's what I lack on, and I think a lot of us realize that this summer, that's what we lack. So I felt it was a seminal article to me in my clinical practice. So 300 plus years, and they only have one type of pain research, one type of pain theory. That sucks. In the 50s, 60s, Malzac and the guys up in Canada and some pharmaceutical agencies, companies, started researching pain more. And we came up with dozens of theories. That's the problem though, theories. So we don't fully understand pain yet. And I don't want to be pessimistic, but I don't think we ever will. Hopefully we do. More research needs to be into phantom limb pain. Borghi et al. 2010 talks about phantom limb pain. There are a ton of articles coming out on this with the Iraq War, the Afghanistan, go over there about phantom limb pain, individual soldiers losing limbs and still having pain when they're amputated. Why is that? Spinal cord injury. We don't know enough about spinal cord injury yet either. 3 articles that talk about spinal cord injuries and trying to do manual therapies to help them, and they got better. Their pain decreased. We'll talk about some of these. Phantom limb pain. So this guy studied 71 patients undergoing lower extremity amputation. Again, they used a catheter with pain medication during surgery and can continue this up to 90 days after surgery. Patients were told whenever they had limb pain, they could push the button, it would give them the analgesic. Once their pain, though, got to a 1 out of 5 on a scale, they were to remove the catheter, and they instructed them how to remove that. Out of all 71, actually not 71 patients, 9 patients died in this study because of other complications, mostly cancer. So roughly 62 patients finished the study in an average of 62 days. They had the catheter out, but they still had phantom limb pain. How come? Some of these studies suggest that it could be due to the dorsal horn of the spinal cord, but we don't know. We really don't know why individuals get phantom limb pain. My grandma was diabetic. She had her knee amputated, her lower leg amputated below the knee. I remember as a little kid, I was probably 6 years old at this time, I didn't understand it, that she would complain of her foot hurting. And I always ask her, why, Grandma, you don't have a foot? How can that happen? Bailey, 92, did a counter-strain study. In his research, muscles stretched, right? Spindles are activated, stretch reflex occurs, putting the muscle in a relaxed position. Can that decrease the stretch reflex and then decrease pain? I don't know. A lot of these counter-strain studies that came out were 2 slides ago with the spinal cord patients. With spinal cord patients, they have pain, right? They can't feel anything, dermatomal patterns, can't move anything, but they still have pain. So how does that happen? So a lot of the research I was looking into were osteopathic physicians doing strain counter-strain to a point, doing some positional release therapy on these patients, and they decrease their pain. That's awesome. Yeah, they might be a quadriplegic or a paraplegic, but they still shouldn't have to live in pain, right? So if you're, paralyzed from the waist down, you should not have to live in pain. Nobody should have to live in pain, but you shouldn't have to live in pain every single day. So by doing some of these techniques in spinal cord patients, I think that we can learn more basic science. So positional release technique is thought to act on the nociceptive system by relaxation of the surrounding tissues. The D'Ambrosio book I received a couple weeks ago in the mail has been awesome. May have an indirect effect on chemical mediators on inflammation. So tender point could be a dysfunction. In positional release, you're taught to find the tender point, and then in the textbook it shows you how to properly put them in the position to release this tender point. You hold it 90 seconds, and I've had awesome success with this. So I'm very, very intrigued in this. So my 10 questions: can a manual therapy such as PRT help decrease chronic pain? Which pain theory would PRT fit into? Is there a way to measure the neurochemical makeup of pain pre and post PRT? I know I couldn't do that here in my clinical setting. Which pain theory is actually the best? What is the best definition of pain? Which is better treating pain, with a modality or manual therapy? That could be acute or chronic pain. What manual therapies can we use for phantom limb pain that might translate into general patient population? So we can take these individuals and can we generalize it to the general patient population? I don't know. Are drugs the best route for decreasing pain, or can manual therapies be just as effective? Research has shown some promise in the manual therapies for spinal cord patients. There's an Arnetti article again. Can this translate into general population? And then again, basic scientific research into nerve fibers, their mechanisms on the spinal cord needs to be studied further. And instead of being a theory, can we prove the gate control theory? Instead of it being a theory, can it be the gate control? I don't know, whatever else we want to call it. And again, here are my articles that I have. Hope you enjoyed the presentation. And again, I may have went a different route than many of you, but I hope I still got the point across. Thank you.